Hey, welcome to the deep dive. So glad you're with us.
hmm
Especially you, our listener. Maybe you're a nursing student right now, really grappling with this complex but, well, absolutely vital world of pediatric health. Today, we're diving deep into something specific: pediatric neuromuscular and muscular dysfunction. And our source material for this, it comes straight from your notes, really. Insights pulled directly from a key nursing textbook chapter that covers this exact area. So our mission here is to kind of cut through all the density, maybe, and zero in on what you really need to grasp as you prepare to care for these kids. We're going to unpack the pathophysiology, the essential, what's happening inside the body, then connect that to the signs and symptoms you'll actually be assessing for. And really importantly, spend good time on the nursing care, the interventions, the treatments, including those specific medications you might encounter. Think of this as your focused study session guided by the source material.
Exactly. And truly understanding the why, the mechanism behind these conditions.
hmm
Well, that's just foundational for nursing, isn't it? It's what helps you predict what a child might need, understand why a certain intervention works, and ultimately give care that's, both really skilled and compassionate. We're not just talking diagnoses here. We're talking about the lives of children and their families.
Okay, then, let's get into these notes. Right at the start, the material really hammers home that a thorough assessment is just, well, it's non-negotiable. So
Yeah.
when you're evaluating a child, looking for potential neuromuscular issues, what are those foundational pieces you need to look for, according to these notes?
Right. Well, you have to start with a really keen eye on their motor development. Like, are they meeting those expected milestones? You need to observe their movement patterns, their coordination. That gives you your first crucial clues.
So watching how they move, not just if they can move, makes sense.
Precisely. Then you assess muscle tone.
Right.
Are they hypotonic? Sometimes people say floppy. Or are they hypertonic, seeming stiff or rigid? These are opposites, obviously, but equally significant findings.
Floppy or stiff? Okay, those terms really paint a picture and can narrow things down.
They do. And also check reflexes. Both the primitive reflexes, the ones that should have disappeared as they get older, and the deep tendon reflexes. Pay close attention to their gait, too, and their posture. The notes specifically call out signs like walking on their toes, or that characteristic way some kids use their hands to push themselves with their legs to stand. That's known as Gower's sign.
Gower sign. Yeah, I remember seeing that mentioned specifically. That description was quite striking in the notes. Can you maybe paint a clearer picture? What does that actually look like?
Sure. So imagine a child trying to get up from lying or sitting on the floor. Instead of just, standing up smoothly, they might first get onto their hands and knees. Then they'll plant their feet flat. And then they'll literally walk their hands up their own legs, up their shins, to their knees and their thighs, just to get upright. It's a very visual sign of weakness in those proximal muscles, especially the hips and thighs. It's a really important physical clue.
Wow. Yeah, that's a powerful image. That definitely sticks with you. Okay. And finally, assessment-wise.
Assess their functional mobility. How do they manage activities of daily living, or ADLs? What can they actually do independently versus what needs help? This really sets your baseline for planning care and identifying goals.
Right, the baseline. Assessment informs everything that follows. Okay, so the notes mention cerebral palsy briefly here. It says it's a non-progressive brain injury affecting muscle tone and movement, but acknowledges it's often covered in more detail elsewhere. It lists the types: spastic, dyskinetic, ataxic. So while we're not doing a full deep dive on CP itself today, what do these notes highlight as the key treatment approaches?
Yeah, for CP, the notes really stress a multimodal approach. It's all aimed at maximizing function and managing the symptoms. They emphasize physical therapy, occupational therapy, using orthotics for support, and importantly, they list medications like baclofen and also Botox injections to manage spasticity. And they mentioned the potential need for surgical intervention sometimes too.
So really focused on managing the lifelong impact of that initial non-progressive injury. Okay. Let's shift then to something that often needs immediate intervention: neural tube defects, specifically spina bifida, or maybe more precisely, myelomeningocele. This is that congenital issue where the neural tube just doesn't close completely during pregnancy, right?
That's correct. And the notes make an important distinction between spina bifida occulta, which is often hidden under the skin, maybe doesn't cause major issues, and spina bifida cystica, where there's a visible sac protruding. Within cystica, you have meningocele, which is a sac with just spinal fluid and meninges, and then myelomeningocele, which is the more complex, more severe form, where the sac also contains parts of the spinal cord and nerves. That distinction is absolutely vital because myeloma leads to significant neurological deficits.
And those deficits, they typically show up below the level of the defect itself, affecting movement, sensation, bowel, bladder control.
Yes, exactly. Muscle weakness or paralysis, lack of sensation down there, and neurogenic bowel and bladder are very common. Orthopedic issues like foot deformities or hip problems are also frequent. And importantly, a large percentage of these children develop hydrocephalus, that's excess fluid on the brain, often needing a shunt to manage it.
A shunt, right. Which brings its own set of critical nursing assessments and potential complications we need to watch for. So, for a newborn who presents with that visible sac, what is the absolute first, most immediate nursing priority?
Preventing infection. That's paramount.
Okay.
The notes are very clear. Immediately cover that sac with a sterile dressing soaked in saline. Sterile saline. Protecting that exposed neural tissue is the #1 priority before surgical closure can happen.
Okay, sterile saline dressing. And surgery usually happens quickly.
Typically within the first 24 to 72 hours after birth, yes.
And then the long-term nursing care after that initial surgery, what does that involve?
Oh, it's extensive.
Huh.
And very multidisciplinary. Managing mobility is huge, often involving braces, maybe wheelchairs later on. Implementing really rigorous bowel and bladder management programs. This is critical to prevent kidney damage down the line and help with social continence. Meticulous skin care is essential too because of that decreased sensation. They're at high risk for breakdown and, like you mentioned, vigilant monitoring of that shunt if they have one for any signs of malfunction or infection.
That's a really comprehensive long-term picture. Okay, now let's talk about the muscular dystrophies. These notes focus mainly on Duchenne muscular dystrophy, DMD. Described as the most common and severe type, it's inherited in an X-linked pattern, onset usually between 3 and 7 years old. The core problem here, the notes say, is the absence of a protein called dystrophin. What does that actually mean for the muscles? What does dystrophin normally do?
Okay, so think of dystrophin as acting like a shock absorber or maybe structural support right within the muscle fiber itself. Without it, the muscle fibers are incredibly fragile. They get easily damaged just by the normal stress of movement. And over time, this repeated damage leads to progressive degeneration of the actual muscle tissue, which then gets replaced by non-functional stuff, basically fat and connective tissue.
So the muscle itself essentially wastes away and gets replaced by something else that doesn't work.
Precisely. Clinically, what you might see first is maybe delayed walking or the child having trouble keeping up with peers, running, climbing stairs. That Gower sign we talked about, very common in DMD. You also often see calf pseudohypertrophy. The calf muscles look unusually large, bulky even.
Ah, yes. The notes mention that. Is that the fatty infiltration you were just describing? So it looks big, but it's actually not strong muscle.
Exactly right. It gives the appearance of muscle bulk, but it's actually weak tissue replacing the muscle fibers. The defining feature is that progressive weakness. It eventually leads to loss of the ability to walk, usually by the early teen years. And tragically, the weakness also affects the heart muscle and the respiratory muscles. This leads to respiratory and cardiac failure, often later in adolescence or early adulthood.
Diagnosis involves checking CK levels, which would be elevated, right? Genetic testing, sometimes a muscle biopsy.
Correct, on all counts.
And treatment. The notes state there's no cure, but treatments can slow things down.
That's right. The main goal of treatment is really slowing the progression and managing the complications that arise. Corticosteroids like prednisone or deflazacort are specifically mentioned in the notes. They play a role in preserving muscle function for a longer period. Physical therapy, occupational therapy, absolutely vital for maintaining flexibility and function as much as possible. Using assistive devices becomes necessary as the weakness progresses. Respiratory support becomes increasingly critical over time, often needing non-invasive ventilation like BiPAP and cough assist devices to help clear secretions. Cardiac monitoring and treatment are essential too. And of course, robust psychosocial support for both the child and the whole family is needed throughout this really difficult progressive journey.
Okay. Now here's where it gets really interesting, I think. Moving from genetic issues to acquired ones. Guillain-Barré syndrome, GBS. These notes describe it as an acute autoimmune attack. It causes demyelination of peripheral nerves, and it's often triggered by some kind of infection or sometimes a vaccination. What does this autoimmune attack on the myelin actually do to the nerves?
Okay, think of your peripheral nerves like electrical wires running from your spinal cord out to your muscles and skin. Myelin is like the insulation, the coating on those wires. It allows the nerve signals to travel really quickly and efficiently. In GBS, the body's own immune system mistakenly attacks and strips away this myelin insulation.
Like stripping the plastic coating off an electrical wire.
Exactly like that. And without that insulation, the nerve signals get slowed down, distorted, or sometimes completely blocked. This basically prevents the brain from effectively communicating with the muscles. The classic presentation, the one described in the notes, is that ascending paralysis and muscle weakness, meaning it typically starts in the feet and legs and moves upwards, ascends through the body.
Ascending paralysis, that pattern seems like a really key diagnostic clue.
It is, definitely. The disease usually follows 3 phases. There's an acute phase where the weakness gets worse, then a plateau phase where things kind of stabilize for a bit, and then hopefully a recovery phase as the nerves slowly start to repair themselves and remyelination occurs.
And nursing care, treatment, what do the notes highlight?
Supportive care is absolutely fundamental, especially meticulous monitoring of respiratory status. That's because the paralysis can ascend high enough to affect the diaphragm and the muscles needed for breathing. That's a medical emergency. Nutritional support is also key if swallowing becomes impaired. Then there are specific treatments aimed at modulating that faulty immune response. The notes mention intravenous immunoglobulin, IVIG, or plasmapheresis. These therapies work either by providing healthy antibodies or by filtering out the harmful antibodies that are attacking the myelin. Pain management is often necessary too, and physical therapy is absolutely vital during what can be a very lengthy recovery phase.
Okay, let's look at spinal muscular atrophy, SMA, another genetic condition, but a different underlying cause than DMD. The notes state SMA is due to degeneration of anterior horn cells in the spinal cord. What exactly are anterior horn cells, and why is their degeneration such a problem?
Okay, anterior horn cells are specific types of motor neurons. They're located in the gray matter of the spinal cord. They're essentially the command centers that send the final signal from your brain and spinal cord out to your skeletal muscles, telling them to contract. When these cells degenerate in SMA, they basically die off.
So it's not that the muscle itself is inherently faulty like in DMD, but that the signal telling the muscle to work can't get through because the command center, the anterior horn cell, is deteriorating.
Precisely. You've got it. The muscle might be perfectly fine initially, but without that nerve signal from the anterior horn cells, it just can't be activated. And this leads to progressive muscle wasting, atrophy, and weakness. It's a problem with the nerve supply to the muscle. The notes describe different types, usually based on severity and the age when symptoms start. Type 1, also called Wernicke-Hoffmann, is the most severe. It often presents in infancy and historically had a very poor prognosis without intervention.
And this is one of those diseases where treatment has changed dramatically just recently, right? The notes mention new gene therapy options becoming available.
Absolutely. This area is evolving incredibly rapidly. The notes specifically highlight treatments like Zolgensma, which is a one-time gene therapy, and also Spinraza, which is an antisense oligonucleotide therapy given via spinal injection. These therapies work upstream from the muscle. They basically help the body produce more of a specific protein, SMN protein, which is essential for the survival and function of those motor neurons, the anterior horn cells. They've fundamentally changed the prognosis for many children with SMA. It's really remarkable. But alongside these newer therapies, supportive care remains critical. Things like respiratory management, which is often intensive, sometimes requiring mechanical ventilation in severe types, and nutritional support, frequently needing a G-tube, are still vital nursing responsibilities. Multidisciplinary care is key.
It really is incredible to see how treatment has advanced for conditions like SMA. Okay, finally, the notes include 2 examples of acquired neuromuscular issues caused by bacterial toxins, botulism and tetanus. First, botulism, caused by a neurotoxin from Clostridium botulinum. How do infants typically get this, and what clinical signs do you see?
Yeah, infant botulism usually happens when an infant ingests Clostridium botulinum spores, often linked to honey, which is why we say no honey before age 1. But it can also come from environmental dust or soil. The toxin produced by these bacteria works by blocking the release of acetylcholine at the neuromuscular junction. Acetylcholine is the neurotransmitter that signals muscles to contract. So the signal is effectively stopped before it reaches the muscle. The classic signs described are generalized hypotonia, and there's that floppy baby presentation again, along with constipation, which is often the very first symptom parents notice, poor feeding, a weak suck reflex, maybe a weak cry, and respiratory distress can develop if the breathing muscles become affected.
Floppy baby, constipation, definitely important clues to connect.
Yeah.
And treatment.
Supportive care is absolutely paramount, especially respiratory support if they need it, and managing nutrition. The specific treatment mentioned in the notes is botulism immune globulin, or Big DIOM4. It contains antibodies that help neutralize the circulating toxin.
Okay, and then tetanus. Caused by Clostridium tetani spores, usually getting into the body through a wound. How does this toxin work? It sounds almost like the opposite of botulism.
It is, in a way. The tetanus toxin interferes with the nerve signals that normally inhibit or stop muscle contraction.
Yeah.
So instead of blocking the go signal like botulism toxin, tetanus toxin blocks the stop signals. This leads to uncontrolled, intense muscle spasms and rigidity.
Like the classic lockjaw.
Exactly.
Mm.
The notes mention early signs like a stiff jaw trismus and maybe a stiff neck. This can progress pretty quickly to generalized muscle rigidity, opistatos, that's a severe arching of the back, and really painful, violent muscle spasms that can be triggered by almost any stimulus, touch, sound, light. If the respiratory muscles get involved in these spasms, it can be fatal.
That sounds absolutely terrifying. Prevention must be key, mainly through vaccination.
Absolutely.
Yeah.
Vaccination with the DTaP series is the primary preventive measure. It's highly effective. If tetanus does occur, treatment is intensive care. Focuses on managing the airway and breathing, often requiring sedation and ventilation, using muscle relaxants to control those severe spasms, administering tetanus immune globulin, TIG, to neutralize any unbound toxin, and giving antibiotics to kill the Clostridium tetani bacteria that are producing the toxin.
Wow. Okay, so that's a lot of different conditions causing motor dysfunction. We've seen genetic problems with the muscle structure itself or the nerve cells, autoimmune attacks, toxin-mediated issues. But as you said earlier, they often share many challenges for the child and family. So bringing it back to you, the nursing student listening, what are the overarching nursing management principles that kind of apply across many of these conditions based on these notes?
Yeah, the notes really emphasize a few key priorities that come up again and again. Promoting mobility and function is central. That means working closely with PT and OT, utilizing orthotics or braces, recommending adaptive equipment to help them participate as much as possible. Preventing complications is also critical. Things like maintaining skin integrity, especially if sensation or mobility is impaired, preventing joint contractures through range of motion exercises, and managing common issues like constipation, which affects so many of these kids due to reduced mobility and sometimes nerve involvement.
And respiratory status came up repeatedly across almost all these conditions, didn't it?
It's a huge nursing focus. Monitoring respiratory effort constantly, managing secretions, having suction readily available, administering oxygen if needed, and managing respiratory support devices like BiPAP or even ventilators. These are often life-sustaining interventions. Nutritional support is also frequently needed. Sometimes this means enteral feeding through a G-tube to make sure they get adequate intake and prevent aspiration, especially if swallowing is affected.
And it's clearly not just about the physical care, the tasks.
Not at all. The psychosocial support needed both to the child and their family is just immense. These conditions can profoundly impact body image, social interactions, school, and they require significant coping strategies from everyone involved. For the progressive conditions, nurses play a really vital role in helping families navigate incredibly complex decisions. Sometimes that includes discussions around palliative care or end-of-life care when that's appropriate. And education is absolutely fundamental throughout, empowering families with knowledge about the condition, medications, equipment use, and importantly, how to recognize signs that things might be worsening or that a complication is developing.
Okay, we have covered a lot of ground here. We started with those essential assessment skills. Then we looked at specific conditions like spina bifida, Duchenne muscular dystrophy, GBS, SMA, understanding the underlying pathophysiology, recognizing key signs and symptoms like Gower's sign or pseudohypertrophy or that ascending pattern in GBS, and detailing the specific nursing interventions, treatments, and key medications like baclofen, steroids, IV-IG Spinraza, all outlined in your notes. And we also pulled out those really important overarching nursing management principles that apply across the board when caring for children with these neuromuscular and muscular dysfunctions.
Yeah, I think this deep dive gives you, the listener, a really solid foundation because understanding the why, the underlying pathology, that's what truly enables you to make sense of the assessment findings and anticipate the child's needs. Your role as a nurse in maximizing function, preventing complications, and providing that crucial holistic support to the child and their family, it's absolutely critical. It makes a huge difference.
Absolutely. This information is such an essential stepping stone as you move into your clinical practice.
And maybe, as you reflect on all this material, consider this, sort of a provocative thought to take away. How does understanding the progressive nature of some of these conditions, like Duchenne muscular dystrophy or severe spinal muscular atrophy, how does that fundamentally influence the goals of nursing care and the support provided to the family over time? Especially now when we have new treatments, like for SMA, that are actually changing the trajectory and extending life for some children. What does that shift mean for the nurse's role in supporting long-term adaptation and quality of life?
That's a really important question to sit with as you take this knowledge forward. Thank you so much for joining us for this deep dive. We really hope this helps you feel more prepared and maybe a bit more confident as you embark on caring for children facing these complex challenges.